What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
I am Matt Covington, and I want to welcome you to the Radiology Review podcast. This episode will continue our discussion of nuclear medicine therapeutic and theranostic agents and will focus on PSMA and radium therapies for prostate cancer. A free downloadable study guide on this topic can be accessed on my website, theradiologyreview.com, under the study guide section. I wish to remind you that I have a discount code section on my website where you can frequently find discount codes for radiology educational resources, including online question banks. And while you are there, check out some of the articles on the Radiology Review Insider that may be of interest to you as a member of my radiology audience. And without further ado, let's get into the questions and answers for this episode. Note that this review is for educational purposes only for radiology and nuclear medicine board preparation. Any doses or treatment paradigms that I might discuss should be confirmed and administered according to the product labels and accepted medical society standards. First, let's start with Lutetium-177 PSMA therapy. And the questions I am addressing on this episode are more specific to Pluvicto therapy, which is the trade name for a certain type of Lutetium-177 PSMA therapy that is currently in clinical use, but anticipating the future, there may be other PSMA therapies that will be commonly used, and if that is the case, I'll refer you to any product labeling, published articles, and institutional guidelines for any differences that may exist between what is discussed here and PSMA theranostics with other agents that may be in current or future clinical use. PSMA, standing for prostate-specific membrane antigen, is one of the many misnomers in medicine in that PSMA is highly expressed in prostate cancer cells but is not strictly confined to prostate cancer cells, as the name prostate-specific membrane antigen would suggest. PSMA is expressed to some degree in various other tumors. However, PSMA is most associated clinically with prostate cancer, and PSMA-based radiotherapies are currently only clinically available for prostate cancer, but are being studied in current and planned future trials for other malignancies as well. Therefore, an expanded use of PSMA-based therapies for other cancers is something which I could foresee. This episode, however, focuses solely on PSMA use for prostate cancer. PSMA agents have been developed with positron and gamma emitters for imaging and with beta or alpha particles for therapy. The agents in common current clinical use are positron emitters for PSMA PET imaging, using either fluorine-18 or gallium-68, paired with PSMA therapeutics with Lutetium-177 with beta particles. First question. What is the physical half-life of Lutetium-177? The answer is technically 6.647 days, but I think you can simply remember about 1 week, or 7 days. Next question. True or false? Lutetium-177 PSMA emits both beta particles and gamma rays. The answer is true. After binding to the PSMA binding ligand on the PSMA transmembrane protein, the Lutetium-177 destroys the cell with beta particles, and the gamma rays allow imaging of sites of binding throughout the body for things like dosimetry or imaging to evaluate potential extravasation at the ejection site. Next question. What is the primary route of elimination of Lutetium-177 PSMA? The answer is that renal excretion is the primary route of lutetium-177 PSMA elimination from the body. Next, true or false? After binding to the PSMA receptor, lutetium-177 PSMA is internalized into the cell. The answer is true. Following infusion, the lutetium-177 PSMA binds to target receptors on the cell membrane, and the radioligand is internalized into the PSMA-expressing cells. The beta particles thereafter radiate the target and adjacent cells, causing cell death through DNA damage. Next, what specific subset of prostate cancer patients is lutetium-177 PSMA currently approved for? At least for lutetium-177 PSMA 617, for which the trade name is Pluvicto, therapy is for patients with PSMA-positive metastatic prostate cancer who have been treated with androgen deprivation therapy as well as taxane-based chemotherapy. I think this is an important point that currently we are only treating patients with Pluvicto therapy who have already received androgen deprivation as well as taxane-based chemotherapy, and therefore the prostate cancer is generally more advanced for current use cases. Next, what is the current dose cycle for Pluvicto therapy? Current approved regimens for Pluvicto are 6 separate doses separated by 6-week intervals. If disease progression or unacceptable toxicity sets in, therapy may be discontinued or a reduced dose may be considered for the remaining administrations. More on this later. In dosing for lutetium-177 PSMA, is dosing for lutetium-177 PSMA currently standard between patients or individualized to the patient, such as with a weight-based regimen? Currently for Pluvicto, a standard dose is given intravenously unless dose reduction due to toxicity is indicated, and that standard dose is listed as 7.4 gigabecquerel, which is 200 millicuries. One could ask, given how humans vary greatly in size, shape, body composition, metabolism, renal and liver function, and extent and distribution of disease, whether dosing should be individualized to the patient. I think we all know this is where we need to head, but we aren't there yet. Individualizing doses of radioligand therapies to the patient may require dosimetry to be calculated per patient, and that is not routinely done in current use. Look for this in the future, however. This is of interest to many in nuclear medicine, and I hope we do see the day where therapies such as lutetium-177 PSMA are more individually dosed to the patient. Someday, future nuclear medicine practitioners will probably listen back to this and will probably laugh that we were giving the same dose to everybody, but you have to start somewhere, I suppose. Next question. What are some of the most common adverse reactions to lutetium-177 PSMA? According to the widely published VISION trial, upon which Pluvicto therapy was FDA approved for clinical use, the most common adverse reactions of any grade were fatigue in 43%, dry mouth in 39%, nausea in 35%, anemia in 32%, decreased appetite in 21%, and constipation in 20%. I do not think those percentages are important to remember, but I would relatively remember that these are common adverse reactions, of which the 3 most common at least are fatigue, dry mouth, and nausea, and anemia is also very common in about 1/3 of patients. The most common grade 3 or higher adverse reactions were anemia, thrombocytopenia, and fatigue. Anemia in 13%, thrombocytopenia in 8%, and fatigue in 6%. And these grade 3 or higher toxicities are the ones we pay particular attention to because they are more severe and potentially more problematic to the patient. Next, following lutetium-177 PSMA treatment, how many days should one limit close contact with others and sleep in another room per manufacturer recommendations? Restrictions following Pluvicto therapy include limiting close contact within 3 feet of household contacts for 2 days and with children or pregnant women for 7 days. One should sleep in a separate bedroom from household contacts for 3 days, from children for 7 days, and from pregnant women for 15 days. One should refrain from sexual activity for 7 days. Effective contraception is to be used during treatment and for 14 weeks after the last dose of Pluvicto. Next, what types of symptoms indicate possible myelosuppression following lutetium-177 PSMA therapy? Myelosuppression can manifest as abnormal values on complete blood counts, including low hemoglobin, white blood cell counts, absolute neutrophil counts, and platelet counts. Clinical symptoms of possible myelosuppression include fatigue, pale skin, shortness of breath, bleeding or bruising more easily than normal, difficulty stopping bleeding, frequent infections, fever, sore throat, or mouth ulcers. Depending on the severity of myelosuppression, treatment may need to be withheld, permanently discontinued, or given at reduced dose. Next, besides monitoring a patient's complete blood count, what other laboratory tests need to be monitored with lutetium-177 PSMA treatment? Laboratory tests that also should be monitored include kidney function laboratory tests, including serum creatinine, which should be monitored before and during treatment, as well as liver function tests. Next, true or false? Lutetium-177 PSMA therapy may cause infertility in males. The answer here is true. Radiation exposure to the testes during lutetium-177 PSMA therapy may be sufficient to cause temporary or permanent infertility. Next question. What are options for lutetium-177 PSMA therapy dosage modification if an adverse reaction occurs? In the case of adverse reactions, the dose interval may be increased from every 6 weeks to every 10 weeks per the manufacturer to allow time for recovery between doses. Furthermore, the standard dose may be reduced on a single occasion by 20%, and if the dose is lowered, it should not be increased again in the future. If a treatment delay due to an adverse reaction persists for over 4 weeks, or if the patient would require a further dose reduction due to an adverse reaction, lutetium-177 PSMA therapy should be discontinued. Note that specific guidance from the manufacturer exists on management of adverse reactions that should be referred to in clinical use. In general, adverse reactions such as myelosuppression, renal toxicity, dry mouth, gastrointestinal toxicity, fatigue, electrolyte or metabolic abnormalities, liver enzyme elevation, or other non-hematologic toxicity that is refractory to longer dose intervals as a first intervention for more minor severity grade events, and dose reduction for higher grade adverse reactions require that treatment is permanently discontinued. That is a mouthful. Go ahead and listen to that again or download the free study guide on my website, theradiologyreview.com, to read this in writing. Let's now transition to a slightly more shortened overview of radium-223 dichloride, for which the trade name is Xofigo. And I'm spending a little bit less time on Xofigo because I anticipate you would have more questions on the PSMA therapy, Pluvicto, than on Xofigo, yet both are important and are definitely fair game topics for radiology and nuclear medicine board exams. So let's get into radium-223 dichloride. First, what is the current clinical indication for radium-223 dichloride therapy? Radium-223 dichloride is currently used for targeted treatment of symptomatic bone metastases from castration-resistant prostate cancer. Note that unlike lutetium-177 PSMA, radium-223 dichloride is not intended to treat soft tissue metastases, and a typical candidate for radium-223 dichloride will have no visceral metastatic disease. Next, what type of therapeutic particle is emitted by radium-223 dichloride? Hopefully this is easy in that radium-223 dichloride emits alpha particles. We do not use a ton of alpha particle emitting therapeutic agents currently in clinical practice. Radium-223 dichloride is an example of an agent that emits the alpha particles, and I think that is important to keep in mind. Next question. What are imaging criteria to qualify for treatment with radium-223 dichloride? In short, at least 2 bone metastases should be identified on imaging, and there should be no evidence of visceral metastases. Any metastatic lymph node must be below 3 centimeters in short axis measurement. Again, radium-223 dichloride is really intended to treat symptomatic bone metastases, and the agent preferentially localizes to the bone, and any treatment effect of visceral or large nodal metastases would be expected to be less pronounced. Next question. What is the dose and dosing schedule for radium-223 dichloride? Unlike lutetium-177 PSMA, where everybody receives the same dose regardless of body size, dosing of radium-223 dichloride is weight-based. The exact dose is likely beyond the scope of board exams, but I would remember it is weight-based. Radium-223 dichloride is administered intravenously once every 4 weeks for 6 injections for a standard treatment course. Next question. What are acceptable lab values to proceed with radium-223 dichloride therapy? This is a more complicated question, and you may want to review this in writing as well. But for initial treatment, the absolute neutrophil count, abbreviated ANC, should be greater than 1.5. Platelets should be over 100,000. Hemoglobin should be over 10. And for subsequent treatments, you want an ANC value greater than 1 compared to the 1.5 that was required initially. Platelets to be at least 50,000 compared to 100,000 initially. And there is actually no set parameter for hemoglobin as far as I am aware. However, if hemoglobin declines while on radium-223 therapy, a transfusion of red blood cells may be considered per practice guidelines. Note that lab values are stricter for the first dose, as you want to make sure there is good bone marrow reserve before you initiate radium-223 dichloride therapy, as this primarily will go and treat bone metastases and potentially affect the adjacent marrow. Please confirm all lab parameters with the manufacturer and institutional protocols. However, for board exam purposes, the numbers I've listed should be helpful. Alkaline phosphatase and PSA values may both be helpful to track response to radium-223 dichloride treatment, and both may be considered at baseline and after treatment for monitoring response. True or false? There is a possibility of dose modification if adverse reactions occur following radium-223 dichloride therapy. The answer is true. Radium-223 dichloride treatment may be delayed up to 6 to 8 weeks after the last administration to allow for improved recovery of treatment-related cytopenia between doses. If blood counts do not sufficiently improve within 6 to 8 weeks of the prior dose, despite supportive care, treatment should be discontinued. Next, True or false? Radium-223 dichloride is mostly excreted in the urine. The answer is false. Radium-223 dichloride has more fecal than urinary excretion. Most of the dose goes to the bone, and for what is left over, fecal excretion is the dominant route of elimination. Let me close with some final thoughts. Radium-223 dichloride hit the market first and found utility for treating prostate cancer bone metastases following a clinical trial that not only showed improvement in patient symptoms and skeletal-related events such as fractures, but also a small improvement in survival for patients who had had prior prostate cancer therapies, therefore were very sick patients. Lutetium-177 PSMA is the newer agent that has been shown to extend survival as well and is indicated for treatment of soft tissue and bone disease. Think radium-223 dichloride for bone treatment and lutetium-177 PSMA for treatment of both bone, which is perhaps somewhat limited, as well as soft tissue disease. Also, remember that radium-223 dichloride does not have a paired diagnostic imaging agent and therefore is not a theranostic agent such as fluorine-18 PSMA that allows PET imaging of the targets and lutetium-177 PSMA, which allows for targeted therapy. I hope this episode was helpful for many of you. Remember to download the free study guide at my website, theradiologyreview.com. And while you are there, check out some of the other content that is available there for your interest and educational purposes. You can follow me on Twitter, or should I now say X, at MF Covington, which is my personal Twitter handle, or at RadRev Podcast, as well as on Instagram at RadRev Podcast. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.